We're now going to hear from Dr. Simran Singh, who I'm very pleased to introduce to you.
So I want to expand a bit on what Dr. Warner alluded to with the canines, and that's the spectrum of neuroendocrine tumors. The differences, and I completely agree that no two neuroendocrine tumors are alike, like snowflakes, and I think it's very important for us to first understand what is the spectrum of neuroendocrine tumors, because as I'll lead to, it really involves how we make choices towards treatment and how we decide what our next pathway is going to be as patients and as physicians. So as we've just heard, basically neuroendocrine tumors can arise throughout the body. This really makes it unique, and I think this confuses a lot of other physicians who treat other cancers like colon cancer, breast cancer, because really this can arise from anywhere in the body. These cells can be anywhere. They're very heterogeneous. They can be symptomatic, they can be asymptomatic. We often hear that neuroendocrine tumors or carcinoids are indolent. Often to our center we get patients referred who've been told that, oh, you don't need to worry about this, it's never going to bother you. And sometimes that is the case, but not always. Some of them can be aggressive, and it's very important to try to point out those aggressive malignancies right at the beginning. They can go undetected for years without any obvious signs or symptoms, or undiagnosed. The signs and symptoms are there, but they just haven't been diagnosed, unfortunately. So we're really dealing with a diverse group of tumors here. And I think this is the most important slide that I have today. And it really just emphasizes the different characteristics of the malignancy. These tumors can be metastatic, they can spread, they can be very localized and never spread. They can be, as Dr. Warner pointed out, well differentiated or poorly differentiated. Okay? So all look alike or all look very different. And they can be very indolent and very aggressive. And I think the first step in understanding any individual patient's disease is to try to figure out how we can characterize the disease, because that's really going to decide what pathway we take. Treatment of neuroendocrine tumors can be very complex. As Dr. Warner said, it involves many different physicians, many different healthcare practitioners, and each patient's treatment plan is almost individualized, I think, now. And that's what makes it exciting as a physician to be involved in this care. But I think the first important step is to try to understand the tumor. So why is this important for all the patients? So if the patients in the audience, I think it's important for you to be involved in your care. I think especially in a tumor like this, an uncommon tumor, it's very important for you to be involved in your care and to ask questions and to constantly be reading. And you obviously are, and that's why you're here today, and I think that's wonderful. So you need to find out what type of neuroendocrine tumor do you have, okay? Because not all neuroendocrine tumors are the same. So try to get some understanding of what type of neuroendocrine tumor you have. Classification of neuroendocrine tumor has been ongoing, and it still is ongoing, and it's been very confusing. Confusing for the patient, but it's also confusing for physicians to try to understand of how, in fact, these tumors are classified. And this is a list of many different types of nomenclature and naming of neuroendocrine tumors. And as you can see, it's a very daunting list, and it certainly isn't unified. Previously, the AJCC, which is one of the organizations that we look at in our institution, hasn't really looked at a unified system. It divided it up, and pancreatic neuroendocrine tumors were treated somewhat differently. Lung tumors were staged according to lung cancer, so not completely helpful previously. What we do when we're looking at classification at our institution is we start off with the WHO, or the World Health Organization classification groups. And I really like these because they point out a number of different characteristics that can help predict the behavior of the tumors, okay? And they go from what we call a well-differentiated tumor to a poorly differentiated tumor, and that's somewhat correlated with prognosis, okay? So it can tell us when we need to intervene, how we need to intervene, and to what extent. It looks at metastases. Has the tumor spread or not? It looks at the Chi-67 index, which, as we've heard already, is a marker of proliferation. You notice in the WHO classification, a poorly differentiated tumor has a Chi-67 index of greater than 30%. It considers the size of the tumor, and it also considers what we call infiltration, or how much a tumor is infiltrated into its surrounding vessels. At our institution, we also classify according to the European Neuroendocrine Tumor Society, which to some extent I think some physicians feel comfortable with because it uses a classical TNM staging system. which we use in many other malignancies. It also divides tumor location in foregut, midgut, and hindgut, which I think many physicians are comfortable with. But importantly, it includes grade, and I think that that's essential to any good classification system. And again, it looks at the Chi-67 as a very important marker in terms of helping us understand the tumor. And here you can see that the grade 3, in fact, is Chi-67 is 20%, as opposed to the last classification system, which was the WHO, which had a Chi-67 of greater than 30%. And so why is it so important to figure out grade, or to figure out this Chi-67, or to understand the tumor? Well, this is why right here. It really makes a difference in terms of predicting survival. So when we have a poorly differentiated tumor, or a G3 tumor, I think that we really know that those are aggressive tumors, okay, and their survival is not as good as the grade 1 and grade 2 tumors. And that's an indication to all of us that we need to act on this. We need to use treatment modalities, whether it be chemotherapy, which was my first thought as a medical oncologist, but there's multiple treatment modalities, but we need to be aggressive in terms of our treatment with those diseases. So grade is very important in identifying the tumor. So for the patients, again, I think it's very important when you're meeting with your healthcare practitioners and when you're dealing with your care to ask what your Chi-67 is. Unfortunately, in Canada, in some centers, we don't even do Chi-67, which I think is a problem. And so it's important that we ask if a Chi-67 has been done, and if it hasn't been, it should be stained for. Okay. Another thing we want to look at is, where is the tumor? Where is it exactly? Is it localized? Has it spread? Okay. Unfortunately, because we're not great at detection, I know there's a lot of people that are working to improve this, but often when the disease presents itself, it's actually spread. Okay, and that's true in more cases than we're comfortable with. So it's important to know where is the disease spread to. And why is that important? Well, when you look at a series of, this was a paper by Dr. Yao from Houston, and he looked at the SEER database in the United States, which looked at over 35,000 patients with neuroendocrine tumors. And you can see here that those patients who have metastatic disease, that their survival wasn't as good. So, I mean, that's something we all need to work on, and we need to improve. And I think this really challenges the idea that is sometimes out there, unfortunately, that neuroendocrine tumors are an indolent tumor with very long survivals. And in many cases, that is true, but in some cases, it's not. Okay, so it's something we need to work on. So again, very important to help understand the risk of the tumor. So, as we're alluding to, one of the problems here is diagnosis. Okay, how do we diagnose neuroendocrine tumors? Well, traditionally, history and physical exam is always the first step where we always start with. But as we said, sometimes that can be misleading. And with an uncommon tumor like neuroendocrine tumors, it's often not the first thing that we think of. Characteristic symptoms hopefully set off a flashpoint to us: dry flushing, cramps, diarrhea, abdominal discomfort. But that's not present in everybody. That's really only about 40% of patients present with those symptoms. Biochemical markers I'd like to talk a little bit about. Chromogranin A, which we've heard a little bit about already, is a very important marker which can help in the diagnosis and the treatment of the disease. Urinary 5-HIA is a breakdown product of serotonin, which some people in the room may be familiar with and have done the 24-hour urine collection. And then in specific situations, other specific biomarkers. Imaging can be helpful. CT scans are available widely across Canada. Octreotide scans are generally available in not every location in Canada, but usually by region, and sometimes can be difficult to access, but can be there. And endoscopic ultrasound is a new modality, which for pancreatic neuroendocrine tumors may be useful and promising. So let's talk a little bit about chromogranin A. What is chromogranin A? Well, it's a serum marker, so it's a blood test, okay? And it helps in the detection of the disease. Now, we don't have a lot of information about the detection using chromogranin A. What we do know is it can be elevated. But what we really need to be aware of is that there can be false positives, okay? So protein pump inhibitors such as Losec or Prevacid, common, and it can be elevated with protein pump inhibitors. So that's something we really need to keep in mind. So this is something that can be useful in the diagnosis of neuroendocrine tumors. It can also be used to monitor treatment response. Sometimes when I have patients, we follow the chromogranin A together to see if it's rising or if it's falling. That may give us some indication if our treatment is working or if it's not working, and what we need to do is the next step. Okay? Chromogranin A can also be a predictive marker, and that's important. it can be a prognostic marker, really. It can give us an indication of survival. High levels of chromogranin A have been shown to be associated with decreased survival. And again, this is another one of those factors that we're trying to identify the tumor with so that we can know how to act and what the next best steps are and how aggressive we need to be. Okay? So chromogranin A is one important marker. The urinary 5-HIA is another marker, which for some people may be useful. For patients who have symptoms, often there's serotonin breakdown product in the urine, gives us an indication if our treatment's working or if we have the production of serotonin under control. Chi-67, we talked about already, may call for, a high Chi-67 can call for aggressive treatment. So that's very important to look at. So from a patient point of view, what are other questions you want to ask? What is your urinary 5-HIA? Are you secreting? Or are you not secreting? And the urinary 5-HIA can be part of the answer to that. And what is your chromogranin A level? Okay? And I think, again, in Canada, we've been a bit slower to adopt this, but I think it's becoming slowly adopted across the country. And I think it's something that we should ask our physicians and our healthcare practitioners for when we're looking at a neuroendocrine tumor. I think every neuroendocrine tumor should at least have one chromogranin A level. Then the final thing I want to talk about specifically is what about care patterns? You know, we've sort of alluded to the fact that this isn't a common tumor, it's an uncommon tumor. So what's the best way in treating this? Well, there have been studies that have shown that multidisciplinary care, in fact, probably is associated with better outcomes. That makes sense for something that's uncommon. And not only is this because it's an uncommon tumor, but because, as Dr. Warner pointed out, there's multiple people involved here. So when we have people involved, multiple specialists, having multidisciplinary care can improve survival. And this actually was the impetus for us at our center to start a multidisciplinary neuroendocrine clinic based on the fact that there's so many different specialists involved. This slide here just gives us a bit of information. It again looks at that SEER database, which I think is an excellent source of information. It looked at, again, 35,000 patients since 1973 with a neuroendocrine tumor. And you could see here that the first slide there, the first bar there, sorry, from 1973 to 1987, it shows the survival. It's lower than we are happy with. It's somewhat improved from 1988 to 2004. But you look here, now these are all tumors in the yellow and only midgut tumors on the orange, so it's a hard comparison. But I think the point is still that these are two centers here that have a fair amount of expertise in neuroendocrine tumor. One is in Sweden, in Uppsala, and the other one is in Florida at the Moffitt Cancer Center. Both centers that have interest and expertise in neuroendocrine cancers. And you can see here that their survivals are quite high. Okay? So I think that alludes us to the idea that perhaps having care at a center where there's at least interest in neuroendocrine cancers is associated with better outcomes. This was another paper that looked in Australia at neuroendocrine cancer patients. And they looked basically at the percent of patients that were referred to a medical oncology unit, which was really a multidisciplinary unit. And you could see here from 1985 to 1995 there was a low number, and that number increased over time. Okay? And the difference is that at this multidisciplinary center, when a medical oncologist was involved in their care, there was more use of somatostatin analogs. Okay? Now, why is that important? Why is the use of somatostatin analogs important? Well, because the use of a somatostatin analog in this paper specifically was associated with an increased survival. Okay? So there was a treatment that was potentially beneficial to patients that was helping them over this time period. Again, looking back at trends, we see here that pre and post 1987, which was when we really had the introduction of somatostatin analogs, we do see an increase in survival. Now, of course, this is not because of this one reason alone, but this was one of the major changes in terms of our treatment options in neuroendocrine cancer. So I think somatostatin analogs play a very important role for many patients with neuroendocrine cancers. So again, for the patients, another question to ask, another question to constantly be involved in is, should you be on a somatostatin analog? Is it appropriate for you? It may not be, but I think it's important to ask and to understand that. And to seek care in centers with at least either experience or interest. I don't think everybody has to go to Europe to get treatment. I think we have a lot of excellent centers within Canada, and a lot of interest within Canada is obvious by the amount of faces we have here in this room that have a lot of interest and a lot of expertise in neuroendocrine centers. But I think, and if geography is an issue, I think even having a consultation at some of these centers, just to make sure you can ask some of these questions and be on the right page, and then you can continue with your treatment closer to home. But, you know, I think in almost all regions of Canada, we have centers that at least have a good amount of interest and expertise in this disease. So just to conclude, I think one of the things we really need to work on is classification, and progress is being made, but we all need to, I think for everybody in this room, all of us at some point, including myself, have been very frustrated with trying to understand all the different terminology that's out there. So trying to understand what the tumors are is difficult, and we need to have a clear classification system. A good approach to diagnosing neuroendocrine tumors and thinking about neuroendocrine tumors is important, and I think a big part of that includes a chromogranin A level, okay? And that's important not only in diagnosis, but also in treatment. Care provided at multidisciplinary centers or centers with expertise or interest, I think is very important and optimal if it's feasible. And I think the bottom line, though, is as patients, patients should really be involved in their care in this disease. I think you need to ask questions, you need to have discussions, and you need to be really involved in your care due to the uncommon nature of this tumor. Thanks very much.